I'm going to ask if anyone has any questions for anyone on the panel.
There's a question there, Lynn, on the chat. It asks,
Okay.
Fred, what are the challenges transferring cognitive care plans from the acute sector to the community? What do you see as the biggest facilitators?
Yeah, so cognitive care plans is something that we've been doing with our acute cognitive unit and my service in general, looking at a whole lot of elements that we know work for managing, say, responsive behaviours in people with dementia. And one of the biggest, so one thing we do here is try to keep them pretty compact. So, you know, often you'll see some services providing 8-page plans, and I don't know any personal care worker that would read that. And besides, we also see what happens often when it goes to aged care. Like we have this specialist model of care where we've got a whole MDT, like it's thousands of dollars worth of hours going into, and we know this works for this person in this environment. And so the challenge is then, how do we, you know, how do you care for that in a community environment where not all the things we had in our environment are there? And so one of the things is, you know, how do you communicate that? So we have a nurse navigator that goes out, but then we find often that there are a whole lot of staff in the aged care setting don't even know about the plan. It's been broken up. So we've spent all our time trying to bring this plan into 1 page or 2 pages, and it's been broken up for administrative purposes and reporting by a care manager or a administrative officer, which is exactly what our plans are not designed to do. They're designed to be there at the end of the bed and to actually inform people about really important things in your social interactions with people and leisure. So there's huge challenges there. Well, I was involved in a Dementia Collaborative Research Centre study where we were trying to, you know, have champions in aged care, senior people doing projects and things. And we just don't have people at, I mean, why isn't there CNCs or CNs like myself working in aged care? They're not there. And we know this care is really complex. We know that you've got to have good assessment skills for a whole lot of things. And I suppose it's another reason why I'm hesitant about the psychotropic push, because we do use psychotropics for certain people who've got extremely psychotic symptoms, and they're appropriate. So the big pushback is actually they're not used appropriately because we're not reorganizing these care environments. So I think there's a huge amount of effort about reorganizing care environments. At the moment, we're seeing a massive amount of people arrive into hospital because everybody's scared about using psychotropics or anything that looks different. And so, you know, I think we're only, you know, I think Val probably talked about it before. A few people have mentioned it's going to take a long journey to upskill people in the community, because I know with what we do, it's taken me 1.5 years working side by side every day with nurses for them to upskill just in an 8-bed unit.
Thanks, Fred. Look, I think, you know, with all of us here, we're going to age into our roles and with our passions, and therefore the older we get, the more credibility we might have, like Val, in this area. And the care planning for people with complex needs is complex. And so that's why it's so important to have now, or perhaps yesterday, the specialty of gerontological nursing acknowledged, and Sakini working out the roles and the descriptions there.
But also just on that, you know, like the stuff that came out of my PhD, to me, like it's very easy for me in my hospital to start getting involved in research and not being on the floor. Every time I do that, I hear of these terrible stories. And I'm not saying it's me, right? But I'm saying if you are not visible, walking the floor, like I've been here doing this for 20 years, and I've got junior nurses who are, you know, 21. I'm tall, right? I stand up, I'm 2 meters. People that tall who are 80, who are really angry and going down the corridor, they don't know what to do. You turn up and say, let's do this and this and that. It's so powerful having really experienced people working side by side on the floor and I think we've got to do a lot around how we organize our workplaces so I can stay on the floor. I still want to do my research, but I can stay on the floor and lead teams. I think that's really important. And I don't think that's actually happening. COVID's gutted aged care. Yeah. So, you know, where's the consistency in some of the community? Anyway.
it's a long journey and we won't give up.
Can I ask a question, please? Fred, what is the cognitive test that you're using as part of your assessment tool? Are you using GP Cog or Brewer or what?
Most of the people we see, we're not cognitive testing. They already have a diagnosis, and nearly everybody my service sees in our hospital. So we're inpatient focused. I'm seeing with a geriatrician, so it's a gold standard sort of geriatric assessment. So yeah, we'll use whatever comes our way. A lot of the testing that you would do, I mean, you do a cognitive test, but you primarily a lot of the diagnosis is around history, right? Yeah, detailed history taking and a diagnosis of exclusion. Yeah. And we go through all that process. So we're not too, I mean, we got a memory clinic and they use a bunch of tests. I can't remember what they're using, and they go into ACEs and all these other bigger ones. Yeah.
Because there's some controversy about, you know, the elements of the assessment tool that's being used.
Yeah, I think in my area it's not a major issue, because most of our people are pretty obviously got an impairment. The biggest issue is around trying to differentiate delirium and whether this is delirium or a dementia diagnosis. But we do a lot of history taking. The people in my service, you know, we want a timeline over 3 years, and we really quiz.
Well, I would suggest you go on a timeline much longer than that. I think it's everybody should have, when they're diagnosed with dementia, should have their whole history, what their previous job was, whatever, everything that they had in their past lives, you know, because strangely enough, I heard somebody say on a television program the other day, you don't know how people die unless you know how they lived.
That's right. Yeah.
So
we find a lot of people have divorced, you know, because then their partners are left, or their ex-spouses go, oh, that's why they were like that. That's why they were so horrible, because they had these precursors to vascular dementia, and they're left sort of coming in and caring. We see a lot of that. Yeah.
But having a history of somebody is right at the start of the process. You know, it's some stage of the aging process, everybody should have their history recorded. I don't know what stages yet. There are various stages.
I can see that we've got another question from Yolan. Yolan, do you want to jump in?
Yes, Fred. I did some work for Habencare when they first won the national tender, and the biggest issue, and it was so refreshing to hear your comments about antipsychotics and pain, and that silent pain, because I used to go to aged care facilities and uncover what was the issue with their challenging behaviours, and it came down to pain. Like, we'd have these gentlemen coming in, they were 6'5", on nothing but Panadol with arthritis, and you know, and there was a lot of education with the GPs. Have you been? I know you're working in the acute sector, but is there any, or can anyone else answer? Is there any work being done of GPs regarding pain and dementia? Because that's where it starts when they're first diagnosed with living with dementia. Is looking at their pain threshold, because if they're in pain, nothing's going to work if they're still in pain.
There's some good pain modules in DTA now, and the GP course in DTA is pretty good too. Pain's really difficult, and yes, 60-70% of our people with severe behaviours that we look after in our unit are getting some sort of pain measure that's bigger than more than Panadol, right? So it's not usually the only thing that's part of the factor, but but I would just be cautionary about pain too, because what often you see is when you stop antipsychotics, people use pain relief like antipsychotics. So it's a really complex area.
Yes.
And
yes,
and
it is.
very easy. So again, it comes down to that idea of throwing a medication at something to get rid of something, rather than doing this really, it's usually this really complex work around. So we have a leisure therapist in our unit, and it's so much is on good leisure therapy. Now, if I was to be really critical of aged care, there is not anything about, there's just no capacity.
There's nothing.
There's this group work,
no capacity.
This group work for half an hour. You know, most of the people we look after need individual leisure therapy and its well-being, and it makes a huge difference. So when you get all those elements, so we always had this approach of this combined approach. Medication do have a role in some way, but often it's about trying to reduce the reasons why somebody won't engage in person-centered interactions. So if you've got pain, you're irritable, you won't engage. If you're having seizures and we can't see them, they're little mini ones, if you want something to do that. So if you've got delusions that everybody's going to poison you, then you might need an antipsychotic so that you get through those. So that they do have a place. Yeah.
And also what Val was saying about the history. Now, this particular gentleman I was thinking about, he was from a farmer. He was from a farm, and when his behaviors, they closed all the curtains and everything when they were giving him personal grooming, and looked out to the grass and to fields. And of course, to him that wasn't mourning, because he's used to getting dressed, in front of his window on his farm. And it's so key is that history. I just wanted to make that point.
The history and all the little parts around the talking points, the way you approach conversation. What we teach in our service is to understand, say, stress competence models. And I realize this is all becoming very much around behaviors and dementia, which is obviously this is an older person forum. So this is a very, but it is often a really, we're seeing a huge amount of people in hospital now that probably shouldn't be in hospital because the community can't respond to these behaviors. And so the default position is they end up in hospital. I couldn't think of a more unsafe place to manage half these behaviors.
Absolutely.
There's you got to get through ED first without being sort of completely sedated.
And it just increases their excess disability anyway, once they're there. So
I think we've got time for another question or two, and then Vicky's going to do a little summary of our survey, and then we've got the chief nurse of the ACT is going to wrap up for us. Naomi, I think I saw that you had your, I'm so sorry to cut off this conversation because I'm adoring it, but I have to. Naomi, I think I saw your hand up. Did you still want to ask a question?
Cassia, thank you. I just wanted to comment on, the pain management, what Fred was talking about, because quite often I find that as nurses, we play such a pivotal role in as much as the doctor might be hesitant to chart the pain medication. If as a registered nurse, you go to the GP and say, look, here's my 6 IV pain scales that I've done in the last few days, quite often the evidence is there. So I think, and quite often, nurses in aged care probably don't feel that empowered to be able to actually step up to the platform and speak with the doctor and say, no, actually, doctor, I believe this person is in pain. How about we trial a pain management for the next 7 days or 14 days? If it doesn't work, we'll review then. And I can think of 2 recent examples where I've done that. And, we've gone to a point of almost sending this person to hospital for management to actually having them within the nursing home and quite pleasantly managed. So it is really refreshing to hear these conversations and think, yeah, actually, we have a big role that we play.
Naomi, you should keep doing it there, because every day I have 7 conversations at least with doctors, even palliative care people, about pain and them not believing me. And yet when we actually do an analgesic trial, so it's no better in hospital, it's worse, and it's just as bad. There's a massive opioid overcaution. So if you've had half your guts removed after surgery, two days after, what you find is if you're agitated and aggressive, all opioids will be stopped just immediately. You go, well, on what basis are you doing this? Because opioids cause delirium. Well, maybe the pain's causing delirium. We know pain causes delirium. So there's a whole lot of issues around that. So keep doing it in the community and keep being an advocate.